Thanks very much, Debbie. It's a real pleasure to be with you today and to discuss diagnostics in the COVID-19 pandemic response. As you know, there is really only one test that we are using at present, and that's the PCR. But there are many more potential tests, and that's what Rosanna and our colleagues will be speaking about today, both in Rosanna's presentation and then our panelists. With us, we have Dr. ZIAD MEMISH, who's going to start to give us a current situation update. And ZIAD, I wonder if you would start now, and then we'll introduce people as we go along.
Great, thank you, David. It's a pleasure and honor to be part of this elite group and to present an introductory slides about COVID in the region, and also address the testing strategies that's being followed and the challenges that are faced by different countries in the Eastern Mediterranean region. Can I have my slides? Are they on or?
Sure, 1 second. Let me open up your presentation, apologies. Okay, are they showing?
Not yet.
Not yet.
All right. Let me try this again.
ZIAD, I think they were showing before from your screen, were they? Or was that from Debbie's screen?
It was from my screen, but it's gone now. Let me see if I can.
Can you share again and see if
Yes.
you can maybe pull them up?
Okay,
There
is it on now?
come. I think they're coming, I think, yes.
Great.
There.
Yeah.
Thank you.
Yes, okay, so make them large and then they're on. Great.
Okay,
Thank you,
so
ZIAD.
basically, if you look at the WHO 6 regions and then look at the Eastern Mediterranean region countries, you can see that over the last few days, we've actually reached to the 1 million cases in EMRO, and the total mortalities have reached up to 28,000 mortalities. Our region is composed of 22 countries, and you can see that the different colors represent the different countries in the region, showing where the numbers of cases are actually the highest. And you can see that probably KSA, Pakistan, Iran are leading the numbers of cases in the region. And also, if you look at the mortality that is being reported by country in the region, you can see also the same countries that are reporting a lot of cases are seeing mortalities. Specifically, Iran has a large number of mortality, and that's the one in blue. I guess since the beginning of the pandemic in January this year, WHO released the initial document about testing. And of course, the focus was mainly, as David has mentioned at the beginning, is mainly based on PCR testing, and serology was still being developed. PCR is actually the one test that is being used extensively in our region, plus some use of serology that I think my colleagues will elaborate on in the next few presentations. I think the testing has actually intensified since the DG of WHO said the statement of test, test, test. And I think that was in the middle of March. And that's where countries started to really work hard on increasing the capacity for PCR testing. We have, KSA have invested significantly in PCR testing in the country. Basically, countries across the globe are actually in a race to trying to sort of increase their capacities in testing. Early on, there were some difficulties. There were actually some major difficulties in procuring some of the supplies for testing. And you can see in the States, initially the testing was very small numbers, and then gradually the numbers of tests that were done in the US have gradually increased significantly since mid-March and April onward. We in Saudi have invested very early on in PCR testing. We have the Ministry of Health in Saudi have set up 31 labs for COVID testing, distributed kingdom-wide. We started with 1,000 tests per day, and now we're at the range of 55,000 tests per day. And the goal is to get to 80,000 tests per day by the end of July. And we are supposed to get 14 million tests done by 6 months from now. So basically that's half of the population of KSA, which is a significant number. As of today, we have tested 1.8 million in KSA. The Ministry of Health has also designated hospitals, 25 hospitals with 80,000 beds and 8,000 beds for ICU with 2,200 isolation beds. The ICU beds have actually increased over the last 3 months. The capacity has been increased by purchasing more equipments and supplies, and we're up to 10,500 ICU beds in the country. Also, the government has invested in protecting the businesses, the private businesses, and also people working in these businesses by putting 9 billion Saudi riyals investment into that area. And when it comes to ICU capacity in the major cities in the country, we have huge capacity that was able to absorb the large numbers of cases that were diagnosed over the last few months. There are many, many measures that were done by the government in a staged way. We were one of the early countries to sort of establish a barricade and blocking the borders. We have actually stopped the Umrah, which is something that brings to us 12 million pilgrims per year. There are plans to sort of reduce the Hajj significantly this year. It will happen, but it will have a very limited number of people attending the Hajj this year, with 70% of them being non-Saudis, but that will be all from within the country, within KSA. So there'll be no international pilgrims allowed to come into the country. We also have invested into the drive-through testing. The drive-through testing has started 2 weeks ago. We have 8 large centers already established and 10 small centers that will be opened in the coming weeks. This has actually received a lot of attention from the public because people want to know what their status, especially with the increase in numbers of cases in the kingdom. The last statistics as of yesterday have actually reached 230,000 people who are positive, and the numbers of cases that actually requiring ICU has actually been decreasing over the last few weeks. Now, our region has a diverse populations in countries. We have 22 countries. Some of the countries are well developed economically, like the GCC countries. There are other countries that are going through conflicts and wars, and we worry about these countries because they might have challenges in doing extensive testing in their countries. And this is some work from our colleagues in Yemen, basically sharing their challenges in getting testing done, especially PCR. And I think in conflict zones, having PCR machines is logistically and technically impossible. And I think maybe in regions where there is conflict, antigen detection kits and supplemented with antibody tests will be more suitable for testing instead of using PCR. Also, some of our countries have host a large number of refugees. We have a few million refugees from Syria and Jordan, and also I think 1 million refugees in Lebanon. I'm sure my colleagues will address. These also pose a huge challenge because these refugees are at increased risk of infection and transmission of disease, and also puts a huge burden on the country that is hosting these individuals. Some of the other countries, as I mentioned, Syria and Libya are actually having major challenges with the disease because of the conflict they're facing, which makes it difficult for them to move forward with the diagnostics and treatment. Of course, the status in Egypt, I'm sure we're all following. Egypt is one of the largest countries in our region, population of almost 100 million people. The numbers that have been reported are actually smaller than what everybody has expected. And there are some theories why these numbers are low. Some people say maybe because there is early BCG vaccination. Some people say that maybe there is not enough testing taking place in Egypt. People also saying that maybe the heat and temperature is making the transmission much less than other countries. And of course, there's always a discussion of the subtype of the virus, where there are some subtypes that actually phenotype 1 and 2, which brings milder disease than the phenotype 6. The issue of serology has been a challenge for us in KSA, and I'm sure it's been a challenge for the whole region. I'm sure all of you have seen this report in Nature in April. There are hundreds of kits that are available. We at STAG and other committees in WHO have been discussing the sensitivity and specificity and the validity of these different kits. I think FIND is actually doing the evaluation of different tests to give us some indication of which tests have high sensitivity and high specificity. In KSA, I think there were a few million doses, a few million kits have been purchased, and limited testing for serology is being done, but not at the large scale compared to what's happening with PCR. And I think I'll stop here and let my colleagues take it from there. Thank you.
Thanks very much, ZIAD, for a very clear presentation. And we'll save questions until the end. We'll go through a few presentations, and then we will have some questions. And I will just try now to give you an update on where we understand with the current situation of COVID-19. And I'd like to review with you the epidemiological knowledge, where there are gaps, and what needs to be done. And I think you're now seeing my screen, is that correct?
Yes.
Yes, yes.
Okay, good. Thank you. You know, the SARS coronavirus 2, the cause of COVID-19, is one of the largest RNA viruses known. And it's unique in the viral RNA community in that it has a proofreader. So it actually makes fewer errors when it reproduces than do other RNA viruses, which you know are very unstable, like the influenza virus. It's roughly a spherical virus enveloped in particles with club-like projections, the spikes or the corona that surround these viruses. And they're about 120 to 160 nanometers in diameter. So they're a virus that is unique because of the fact that it makes fewer errors in reproduction and transcription than do other RNA viruses. As you'll know also, there are actually 4 human coronaviruses on this table at the top. They're the alpha coronaviruses and some beta. And you can see that they have come from usually bats or another rodent, a rat, into an animal, likely, and then into a human. And these cause seasonal epidemic of common cold. They peak in the winter, in the early spring. They cause a mild disease. And again, like for the current pandemic, the elderly are hit the most. The elderly have the most serious colds that occur from these viruses. Then there are 3 coronaviruses that have come into human populations in the last few years. Since 2002, actually, is when it emerged in human populations, the SARS coronavirus. The SARS coronavirus is thought to have come from a bat into a civet cat in a live animal market in China, and then infected humans. Through a massive effort, it was eliminated from human populations, but it also had a very different place in which it reproduced than does the SARS coronavirus 2. It produced lower in the lungs, and therefore it was more difficult for it to aerosolize and to become droplets and get out of the lungs. And also, people who had this infection weren't highly transmissible until 7 days after, or not 7 days, but until a period after the onset of signs and symptoms. So the SARS coronavirus was with us. It was in human populations, transmitting widely, and it then disappeared from human populations. The MERS coronavirus, you'll know better than me, it still is emerging from time to time into humans. And the way it transmits is in nosocomial transmission in hospitals or by direct, close human-to-human contact. The people who have comorbidities are certainly at more risk for this infection, and it also has caused a major nosocomial outbreak in South Korea. And then there's the SARS coronavirus 2, which has now become a pandemic, and we'll talk a little bit about that as we go on. But I just wanted to show you that in these human coronaviruses that are present as endemic viruses, immunity is really short-lived. What you can see on the left is a study that was done in 1990, and this was a group of controls and people who had been infected a year earlier, and they were all provided with a challenge dose of the coronavirus, HCOV-299E on the left. What you can see is that in those who had previously had infection, the dark dots, there was a rapid recall of antibody, but then it decreased, just as did antibody in those controls who had not been infected before. And it decreased quite rapidly, as you can see, within a year it was decreasing. It started to decrease the 20th month, and then it decreased week rather, and then it increased to the year. On the right side, you can see the immunokinetics of SARS coronavirus antibody. And what you can see here is patient A and patient B. Patient A in green had a steady level of antibody, whereas patient B had a steady level, where patient A, the orange, had a decrease in antibody over time. And if you look at the whole group of 23 persons, you can see that antibody decreased over time. And by 79 months or 80 months afterwards, antibody had decreased to quite low levels. So like the endemic coronaviruses, we know that antibody decreases quite rapidly, although it is developed after infection in most people. If you look at these coronaviruses that are endemic, it's likely that these emerged in the same way as coronavirus 2 has emerged this past year. So looking in particular at the emergence of SARS coronavirus OC43, this is thought to have come, it's a bovine virus, thought to have come from cattle who were infected by rats. And it's thought by some that this may have been the cause of an epidemic of what was thought to be influenza at the time in the 1890s, because if you trace back looking at the virus at a molecular clock analysis, you'll see that this analysis takes you back to about 1890, the time when this epidemic was thought to have been a peak. And this epidemic actually caused 1 million deaths in a world where there were many, many fewer people. It caused neurological symptoms, and quinine was touted as a cure just today, as hydroxychloroquine, another anti-malarial, was touted as a cure early on. So these viruses appear to emerge the same as does the current coronavirus, and they likely did cause very serious illness at the time, but as time went on, they became more adapted to human hosts and they became less virulent. That's only a hypothesis, but it's thought that these coronaviruses, which are endemic, did emerge at some period in time, the same as SARS coronavirus 2 has emerged in this current year. So we know a lot about SARS coronavirus, and this is because even though there are geopolitical tensions in the world that we all know exist, people are sharing data. They're sharing it through WHO, they're sharing it in medical journals. Medical journals are publishing this rapidly in front of the paywall, and there's a lot of information out there. We know how this virus spreads. It spreads by droplets. It spreads in some instances by finer droplets in an aerosol, and there's a feeling that it might even be able to be transmitted through airborne infections through air conditioning systems in certain instances. But this is not yet proven. All we know for sure is that droplets transmit it and that some aerosols do transmit. We know the groups at greatest risk of serious illness are those who have comorbidities, including obesity, and those who smoke. And in addition, we know that people over the age of 75 or 80, especially if they have comorbidities, are at greatest risk of serious illness, although all persons are at risk of infection. Transmission patterns, we believe that there might be some asymptomatic transmission because modelers are telling us that, although there's no hard evidence yet that people without symptoms throughout the course of their infection can transmit. Modelers again think they can, and we'll have to wait till we find more evidence. But we do know that this transmission 1 or 2 days before onset of signs and symptoms at the pre-symptomatic phase. We know that about 6% of infections in Singapore are thought to have come from pre-symptomatic transmission, and this would be similar to pre-symptomatic transmission in influenza or in measles or other respiratory infections. And we know that symptomatic people can transmit this from the time they begin to develop symptoms, probably through 7 or 8 days after infection, after symptoms have onset, and to a maximum of 14 days. So we know a lot about the transmission. We also know that it transmits differently from influenza because this virus causes discrete outbreaks that can be contained, and therefore transmission prevented in the community. So if there are cases that are discrete cases and they're isolated, and then contacts are traced and they self-quarantine, they themselves they are not a source of transmission in the community, and decreases in transmission and reproductive numbers can occur. We know that there's a need for rapid diagnosis, and I'm not going to dwell on this because I know Rosanna and our panel will do that. And we know that there are uses for masks. Masks do not in any way replace physical distancing, which is the primary way of preventing transmission from people to people. But if masks are used by everyone in closed areas, it does prevent others from getting infected. So we know that we should use masks to prevent infection of others when we can't physically distance, and that includes in dealing with patients who are sick, providing full PPE for those. And we know the importance of physical distancing and hand washing. We know that this virus transmits very easily. Many of you will have seen this diagram. This is a person who was ill in red, who had symptoms of a common cold and went to a 2-hour choir rehearsal for his church in the northwest of the US. During that 2-hour choir, probably through aerosolization of droplets when the person was singing or coughing, 32 confirmed and 20 probable cases of infection occurred during that one super spreading incident. So we know that if we're in a closed space like this, the only way we can prevent transmission to others if we're sick is by wearing a mask. And we need to be sure that we do wear masks if we are sick. We also know that case fatality or infection fatality rates vary by age. And this was Neil Ferguson who did some modeling and suggested that the estimated infection fatality rates are much greater, of course, in the elderly. And what this graph shows us is that overall, about 1.8% infection fatality ratio occurs. It's much lower in younger people. It's very high, up to 9% in those who are 80 years or over. So we know that age is a very important factor in mortality in this infection. And we know that deaths are increasing rapidly. And you can see here the 100,000 marks that were reached in various levels. And we've reached another 100,000 mark just recently. And there are now just over 100,000 deaths reported in the world. That's actually many fewer than we would anticipate in a pandemic such as this, but it's still 500,000 too many in a world of 7.7 billion. We know, as we said earlier, that antibody does occur. Antibodies created to the common coronaviruses. It's also to SARS coronavirus 2. We just don't understand a lot about those antibodies yet. And we know also that there is T-cell immunity created. What we do know, though, is, and Rosanna is going to talk a lot more about this, is that antibody really doesn't start to be detectable until early in week 2 after infection. And here you can see the IgG in green and the IgM antibody that's produced after infection. The IgM increasing, as does the IgG, and then decreasing rapidly, while the IgM and IgG antibody, stays at a higher level. We know there are ways to stop transmission, even though we don't have vaccines and drugs. Shielding of populations at risk is very important, making sure that the elderly, those with comorbidity are protected. We know that we need to diagnose patients rapidly, get them isolated, and make sure that our hospitals have a surge capacity and PPE for health workers. We know that contact tracing and isolation of contacts for 14 days can prevent transmission into the community and contain outbreaks, unlike for influenza. We know that mitigation is very important. As ZIAD said earlier, Umrah and the Hajj have been canceled or postponed. Mass gatherings are a place where transmission can occur and they must be stopped at present. Epidemiological approaches to forced physical distancing have been shown to be important. Doing a circuit breaker type activity, closing down a sector where there's increased transmission, then opening it up again, as has been done in Hong Kong and in South Korea for nightclubs, as has been done in Singapore when there was transmission in schools. And finally, we know that community engagement and participation in outbreak containment and personal protection is very important. We have to be good communicators. ZIAD showed what was going on in the Middle East. I'll just show you what's going on in the world. And you can see in this graph of the world that at the top, Africa still has very low levels of transmission, at least very low levels of transmission causing disease that's recognized. And Africa also has very little mortality. You can see then that the Americas have a great share of the transmission. The Eastern Mediterranean, the area that ZIAD talked about, Europe, the blue, Western Pacific, and Asia are still having less transmission. And so countries that we look to in the future, including the CDC where I used to work, are actually institutions which are not leading the way because politics have many times interfered with good public health in both North America and in some countries in Europe. And so what we need to do as public health people is make sure our voice is better heard. This is showing you the actual cases and deaths around the world. And again, as I said, if you look in Africa on the left, deaths have remained on the black line very low compared to in other parts of the world. And deaths in other parts of the world are either coming down or, as in the Eastern Mediterranean region, increasing slightly, as in Southeast Asia. We know that once a country does suppress this transmission, it can surface again, as has happened in Beijing at the market there, where there has been an increase in transmission, and they've again shut down certain sectors. We know that there are various types of vaccine, none yet available. We're not sure that any will be available in the long term. We know that repurposed drugs are being used. We know that dexamethasone and remdesivir are two drugs that we would like to use in patients. There's plasmapheresis going on to collect IgG, and monoclonal antibodies are being developed, and these look like they may be promising therapies in the future. And we have antigen and antibody tests, including point-of-care diagnostics, which are now being developed. And these are really the only tool that we have to deal with the outbreak at present. And you can see that all those ways of stopping the current pandemic, or at least of suppressing transmission, depend on laboratory testing. And we'll talk more about that as we go along, but it depends on both antigen and antibodies. So what can we envision in the future? Well, our suppression measures have been quite effective in most countries, and suppression has now brought the peak down to a very low level, and we can anticipate that with careful monitoring and containment measures, we will see sustained suppression of transmission. Some countries may not. Some countries may have a glitch. They may have an increase and they may decide to do certain measures again. But people talk about a second wave, and that's the wrong terminology to use for a coronavirus. For coronaviruses, we talk about suppressing transmission. For influenza, we talk about a first wave and a second wave occurring. So try not to use that term of wave. Try to use a suppression of transmission and hoping to keep that transmission low by suppression. So there's one issue that we need to talk about in the future, and that is how to get the goods available to countries. There is the ACT accelerator, which is global solidarity to increase development of vaccines, development of therapeutics, and more importantly, continued development of diagnostic tests, but also getting those tests out into the countries so that they can be used. And WHO is working with all these three pillars of the accelerator in order to develop mechanisms to get the diagnostic tests at present out to the countries that need them. We only have at present PCR. What we need is rapid antigen diagnostics as well as rapid serologies. So I will stop now. I'd just like to thank you for having listened. Again, we'll have questions toward the end to our panel, and I'm going to stop sharing now so that Rosanna can begin to share. And Rosanna will now present her talk. Rosanna, over to you.
Thank you very much, David. And what I'd like to do right now is to be able to share my screen. How do I do that?
Go ahead, just share your screen, yeah.
I can't seem to get to the button to share my screen.
Go down to the bottom of your screen and click.
Yeah, it's not showing here. Sorry.
Rosanna, do you want me to share for you?
Yeah, could you do that?
Let me go ahead. I've got it up now. Is
Good.
this you? Can you see it?
Yeah, are you seeing my screen?
Yeah, we can see it, yes.
Okay.
I'm sharing it, so just let me know when to advance.
Okay, so thank you. I would like to take from where David left off and talk about the various types of diagnostics, but in particular, what do we have now that we could scale up for testing? Second slide, please, Debbie. It's not advancing, no? I can't.
Yes, it's advanced.
Sorry. Okay. So
yeah.
So
I can see it on mine, but maybe.
Okay. Thank you. And so in order to have the right test for the right patient at the right time and in the right setting, we need to think about the three main types of tests that we have on hand. And for each type, we have both a laboratory version, which requires infrastructure and technical people who are especially trained for those techniques. And then we have the point of care versions. And what we have right now is that we do have the laboratory molecular tests, which are quite expensive. And unless you have a laboratory infrastructure that is robust in your country, it'll be very difficult to scale up testing. There are point of care molecular tests that are available, such as the Gene Expert platform, the Abbott test, etc. But they are limited in that the production of these precision instruments are quite take some time, and also the point of care version are a little bit expensive right now. So they're very limited in distribution at the moment. Antigen detection tests would be great, and the point of care antigen tests can be used in community settings as a rapid test, such as the ones that we use for detecting malaria is a rapid antigen test. The ones that we use for detecting dengue is a rapid antigen detection test, and it replaces, in places where molecular testing is not available, it detects viral proteins. So that it could be used to confirm infection, and the test could be completed in 30 minutes and is quite affordable. Unfortunately for COVID right now, we don't have a sensitive enough antigen test to be able to do that. But I know there are some exciting technologies available, and hopefully soon this will happen. There are a huge number of serology tests out there detecting antibody, and I will talk a little bit more about the different ways that we could use them. But for the time being, suffice to say, there are laboratory-based serology tests that are very sensitive and very specific, but they require the use of serum or plasma, so that you need a phlebotomist to take blood. And also because they're high throughput, they're normally used for a huge number of tests, like 3,000 tests a day. And so can you imagine doing a population-based study? Even if you could do 3,000 tests a day, it means that you need a team of phlebotomists to take blood in order to do that. And so logistically, that's a little bit of a barrier. There are rapid tests that are very easy to use, like the HIV rapid test, but they are not as sensitive or specific as we wanted. And those, especially specificity, is very important so that we could distinguish this coronavirus from all the other seasonal coronaviruses in order to help us understand the extent of this pandemic. So next slide, please. So right now, I'd like to, sorry, I think you skipped one slide. Sorry, okay, sorry. Yeah, so before I start to say what are the possible uses, what do we know about this particular virus, infectivity and detection? We do know that the virus can be detected, as David mentioned, days before the onset of symptoms, and can remain detectable in anywhere up to from 25 to 50 days post onset of symptoms. And these are especially important in patients not showing signs of recovery. Viral RNA levels tend to peak within the first 5 days after onset of symptoms and decrease slowly with rising antibody levels. But that viral clearance is not always correlated with rising antibody levels, especially in those who are critically ill. And there's a small study in Germany that showed that even though viral replication have stopped after 5 days after onset of symptoms, a person can remain RNA positive for 1 or 2 weeks after that. And so being RNA positive, we're not sure, is not always associated with shedding a live virus. And that has implications for transmission. Next slide, please. Now, we also need to know that this particular coronavirus, unlike most other viruses, the response is very unusual. Normally, the maturation of an immune response takes about 40 days, and the seroconversion takes anywhere within the first 2 to 3 weeks after onset of symptoms. And usually IgM would precede IgG by about a couple of weeks. But for this particular coronavirus, what's really striking is that the mean time for seroconversion is extremely quick. For total antibody is day 11, around day 11 after the onset of symptoms. IgM is day 12, IgG is day 14. So they're clustered very close together, IgM and IgG responses. And in some cases, the IgM response is quite short-lived and IgG takes over very quickly. And so we could see that this has implications for whether we could use this as a means of identifying cases if you miss doing PCR on them. Next, please. So there have been studies published in China and in other places that showed how combining RNA and serology testing actually improves the sensitivity of diagnosing COVID cases. And so if you look at, in this particular study from China, in the first week after onset of symptoms, in 94 patients, 67% of them are RNA positive, but already 38% are antibody positive, and this is total antibody. And when you combine the two, within the first week, you could already identify 78.7% of the cases. And then in week 2, in 135 patients, 54% of them remain RNA positive, but 89.6% are already total antibody positive, making it possible to identify all cases if you combine the two, instead of just doing RNA or just doing antibody, and so on for the last week. Now, this is not the combination of doing testing is not new. We found that for dengue, and Liz Huntsberger published a study where she showed that if you combine RNA and antibody testing, IgM, for dengue, you could detect over 90% of the cases within the first 10 days after onset of symptoms. The same with antigen. If you combine NS1 with IgM, you could also do the same. And so I give the references there so you could look it up if you're interested. So we should think about this approach as well, especially in those countries where getting access to testing is a barrier. Next, please. And then do we know if these antibody responses that we see are neutralizing? We know from these studies published here that neutralizing antibodies are associated with antibodies against the receptor binding domain of the spike protein and also parts of the nucleic capsid protein. And you could see on the graph to the right that for nucleic acid protein, patients in this study produce steadily rising antibodies from week 1 onwards, and the same with the spike protein. And you could see to the left that the individual patients, you could see the rise of the antibodies against these receptor binding domain and the nucleic acid protein. Next slide, please. But are these neutralizing antibodies correlated with the clearance of virus? Now, what we see in this study from Hong Kong is that in these patients that are documented here, there are severe cases where you see the neutralizing antibodies, anti-nucleic acid protein, IgG and IgM, rising very early and to very high levels in those who's a severe case. Also, the antibodies to the receptor binding domain also rise quite early. In those who have mild disease, the antibodies levels rise more slowly on the whole, but they do achieve the same levels as those with severe cases. But if you look to the graph on the left, which shows you the viral load in these very same patients, you could see that even during the time that they are producing these neutralizing antibodies, almost all of them are still RNA positive. Now, whether they're shedding live virus, we don't know, because in vitro studies on neutralization weren't done on these sera. But we do know that they're RNA positive from either saliva that is collected from the back of the throat or from tracheal aspirates. And so we could see that having neutralizing antibodies does not seem to convey the kind of protective immunity that we would like to see. Next, please. So now, knowing what we know now about the virus, let's try and look at how we could use these rapid serology tests. Now, this will be a combination of what's appeared in the literature as well as from country experiences. So we will consider 5 uses: the rapid triage of suspect cases in communities, especially in countries that have limited or no access to molecular testing, testing contacts of confirmed cases, using rapid serology tests to do situation analysis and surveillance, and also discharge of patients from hospitals, as hospital beds are always in short supply. The sooner you could discharge patients that have recovered, the better. But can we use rapid serology tests for that? And then a lot of talk about immunity passports for not only healthcare workers, but for people in general to return to work. That's been an issue all along. And so let's examine each one of these in a little bit more detail. Next, please. So for the rapid triage of suspect cases, we have a case in Peru, which is a country of 32 million people with very limited molecular testing facilities, a few of them are scattered over the country, and only about 500 ICU beds. The terrain of Peru is such that specimen transport is quite difficult from the high mountains as well as from the Amazon regions into the testing facilities. So very early on in the epidemic, the government decided to institute a hotline and a website where anybody who has symptoms consistent with COVID could call or connect. And interviewer would interview all the callers, and then they prioritize those who are already severely ill, those who are more vulnerable, such as the elderly or those with underlying conditions. And a team would visit the caller in their home so that they don't have to move about the community or come to a clinic. And the home visit team would test the caller who has symptoms with a rapid test. And if the person is rapid test positive and the symptoms are mild, then they're told to isolate and stay at home. But if the situation is such that isolation is not possible in the home setting, then they are taken to a government quarantine facility. Those who test positive but are severely ill are immediately sent to hospital. Now, those who are negative by the antibody test have a swab taken for PCR. Now, this has worked very well because before they instituted this community testing scheme, they were 7,000 PCR tests behind. And so many people were waiting for confirmation, weeks and weeks for confirmation and not getting it. But with this, they are able to do rapid triage of cases in the community and also relieve the backlog of molecular testing and also prevent the healthcare services from being overwhelmed. Next, please. So if we think about testing contacts of confirmed cases, I think that what we've seen in Singapore and other places is that if you only use molecular testing to test contacts of confirmed cases, depending on the timing of the exposure event, people may no longer be PCR positive. And so in some cases in Singapore, they were able to connect clusters of cases using serology testing and therefore be more complete in being able to do a contact tracing that includes all the possible infected individuals. And so I think that there is a use for that in combination with molecular tests. And again, those who test positive should self-isolate, and those who test negative should have a swab collected for molecular testing if possible. Next, please. Now, the third use of serology tests is actually the typical use of serology tests, which is for situation analysis and surveillance. As we know that for coronavirus infections, everybody makes a very robust antibody test, with the exception of maybe less than 10% of the people who have very mild cases or are asymptomatic. They may not make enough antibody to be detectable by the serology test. But on the whole, we could use antibody tests as the most sensitive way to understand the true extent of a pandemic in the population. And with that, we could map the geographic distribution across different places, and also identify hotspots where you need to find out what is happening. Why is there a super spreader amongst them, or is there events, or whether it's a health facility that have not got very good infection control measures, etc. So those hotspots that you could identify are really important. And if you're collecting samples from people who are symptomatic versus not symptomatic, you could also determine the attack rate and identify at-risk populations. And then something that is very important right now is that we could use serosurveys to understand what's going on and then monitor trends over time to see if the public health measures that are in place are effective. And also, as restrictions are being lifted, are we seeing a number of cases? This is very important use of serology tests. Next, please. So now, if we think about whether we could use serology tests to discharge patients from hospitals, or can it be used as immunity passports? I'm afraid that we don't have enough evidence to know that that could be done, because as I have shown before, even though a person is IgM or IgG positive, there is still a fairly sizable portion of those people with antibodies who remain RNA positive, and we don't know whether they're shedding live virus or not. So we cannot be sure to be able to discharge clinically recovered patients from hospitals, or for people to return to work, because we don't know whether they are protected. Now, I give at the bottom of the slide some references because we still don't really understand the concept of correlates of protection for this particular virus. So those challenges are discussed in a review paper that I give the reference to. But I also want to give you the second reference is a World Bank policy brief that says that there are only two tests that could really save the pandemic, and that's molecular testing as well as antibody testing. And if we have, and right now we don't have, if we have a test that could allow us to know that people could return to work safely, and then we could actually save about 2% of the GDP. And they estimated that in a country like Philippines, that could mean $8 billion to the economy, which is significant. So I think that, as David was saying, there are public health decisions that you need to make, but there are also overwhelming political pressure to open up restrictions so that the economy could recover. And so, but right now we just, could be quite dangerous to use serology tests as a return to work test. Next slide, please. So in summary, we would like countries to be able to explore the use of serology tests for rapid triage of suspect cases in the community, for testing contacts of confirmed cases, and in both cases should use molecular tests when you can, but use serology tests as a supplemental test. And also for situation analysis. We don't currently recommend the use of serology tests for discharge of patients from hospitals or as immunity passports. Next slide, please. And in closing, I'd like to acknowledge all the my staff at the International Diagnostics Center, Professor David Heyman, and colleagues at Africa CDC and African Society for Lab Medicine that actually wanted us to look at how we could use serology tests, because in Africa, access to molecular testing was very limited. Colleagues at the Foundation for Innovative New Diagnostics that we collaborate on evaluation of tests, and also at the Federal University of Rio de Janeiro in Brazil. And thank you very much.
Thank you, Rosanna, for a very clear presentation on the ways we can and cannot use serologies at present. So now it's time for the panel, and we have 4 panelists. And what I'm going to do is ask each of those panelists just to introduce themselves briefly, starting with Dr. ZIAD, then going to Dr. George, Dr. SAMEERA, and Dr. Ali. So ZIAD, over to you. If you could just introduce yourself briefly and tell your work.
So ZIAD MEMISH, infectious disease consultant, and I'm working at the Ministry of Health in Saudi Arabia.
Dr. George.
George ARAJ, Director and Professor of Director of Clinical Microbiology at the American University of Beirut Medical Center.
Thank you. Dr. SAMEERA.
I'm Dr. JOHANI. I'm the Director of the Microbiology Lab at the National Guard Health Affair in Riyadh, Saudi Arabia.
Thank you. And Dr. Ali.
Hi, I'm Ali HAJEER. I'm the Director of Immunopathology Laboratory at the National Guard Health Affairs Hospital in Riyadh.
Thank you very much to the 4 of you. What we will do now is Debbie has been collecting the questions that have been sent on the chat system. And so we'll have 3 questions at a time. I think either Debbie will read them or people will ask them. So Debbie, if you could go through the first 3 questions, and the panelists will note down those questions and answer what they can. And then we'll turn to Rosanna for some further answers if there are none that are forthcoming from the panel. So Debbie, over to you.
Sure, thank you. There's been a few questions about some of the specific situations in the areas of our panelists. So I think it'd be a good opportunity to hear from them on their experiences. One of the questions is, I believe is Dr. ZIAD or Dr. Ali, I apologize, who might have raised the question about, or a point about phenotype. So somebody was asking if he could please expand on this. And then the second question is on the practicality around the use of a COVID passport, particularly with some of the slides that Rosanna showed in terms of immunity. And then also, if there are contacts of confirmed cases that are confirmed with serology, should they isolate themselves and for how long?
Okay, thanks, Deb. So let me turn to the panel. Let me turn first to Dr. SAMEERA, and then we'll go from Dr. SAMEERA around. Dr. SAMEERA, do you want to add any replies to any of these?
Yeah, regarding the contact with the confirmed case, I think usually people presented to us to get tested very early on, where usually sometimes they are negative to start with, day 1 or day 2, then they change to be positive within the after 48 hours. Sometimes it depends on the method that we are using, which is, I'm talking mainly about molecular testing because I'm in charge for molecular assays. Sometimes their results, it can be very late positive. Or sometimes people who is familiar with the testing, you can find some of the gene positive and other negative. So usually we ask people to repeat testing within 48 hours. The problem with the molecular assay that the load is so huge on the lab that the result does not really release on time. And I think this is the major issue lab are facing. That, for example, in my lab, our capacity, it's about almost 1,000 tests a day, but we are receiving 1,700 samples a day, which means that, and we are prioritizing inpatient and ER, so which means outpatient contact with a positive case, it may take 48 hours to be reported. So people, they want the result early on. The serology won't be positive very early on, and it's the way to go is the molecular assay. And I do really prefer that contact with a confirmed case, they need to wait at least for a day or two before they got tested. Otherwise, sometimes very early, it may give them false impression that they are okay and they are negative.
Thank you, Dr. Sameera. Dr. Ali, would you like to add anything?
Yes, I will talk about the immunity passport, as Razan clearly suggested and showed that that may not work really as people or as politicians would like to use it. I'll tell you the example of a study that we are doing in our hospital, trying to look for people to donate for convalescent plasma to be used for treatment. What our group did, and they asked people who were infected and identified as PCR positive, and they asked them to come to the lab 45 days after recovery. And surprising enough that more than 50% of them were negative by antibody testing. And that in a way suggests against what we call immunity passport. Because as we know with MERS and with SARS and with other coronaviruses, that antibodies to this type of virus are short-lived. And what we noticed from our MERS studies, we had an outbreak of MERS infection in our hospital, and we noticed that 6 months after infection, in mild cases, most of them, they lost their antibody profile. So it's wise that we look at antibody immunity, if you like, passport concept with caution, and I would vote against it, and I wouldn't really suggest it to any politicians, although politicians would like to use that concept.
Thank you, Dr. Ali. Dr. George, anything to add?
Dr. George had a lot of questions, and there are a lot of insightful things coming out from your talk and Rosanna as well. But I want to start with the issue in relation to the duration of virus detectability. Most of the studies say that after probably 12 days, the majority, you cannot detect any virus. You can detect viral particle later on, like persistence, which they are thought to be kind of part of the virus and not really kind of an infective virus. So we're talking about a short period of time, 12 days, 14 days, many of the studies that came out, and no, you cannot detect them. Whether this is a limitation of the detectability limit of the PCR or not, something else. Now, we come to the neutralizing antibodies. In terms of the neutralizing antibodies, there are a couple of studies which have shown that there are real neutralizing antibodies. The in vivo study, nobody mentioned about the rhesus macaw monkeys, and it was very clear that it has a neutralizing antibody and protective antibody. Then you have some people who were treated with in China, and they tested their neutralizing antibody and they were effective. So what we are having here, we are having a neutralizing antibody that are really potent in terms of in vitro detectability. How? Everybody here, I'm still here, haven't seen a study of follow-up in terms of an appropriate clinical relevance versus time, taking into consideration the different tests, whether molecular, antibody, and antigen detection versus time, in a reliable, credible way of performing a follow-up study. So far, we have many studies which are really have been withdrawn or have been uncredible. And I'm surprised that so far, we are probably 6 or 7 months, if not more, in terms of this infection. And we have many centers, which are global centers, that they should have been able to follow up and do more than 3 weeks or 4 weeks to study to claim, and we have this antibody. Besides, what are the relevant antigens that you are trying to test? What are the relevant antigens in this particular Are they the receptor domain domain, or are they the S spike antigen, or are they the N antigen, and how effective and appropriate in terms of using in terms for antibody detection and for antigen detection. We have hundreds of tests in terms of the antibody testing. Many from the CDC were not approved, FDA not approved. They were in the market and they became not approved. Now there are, as was mentioned, very few antigen detection kits. Now, how appropriate these 4 of them seems to be under under approval or work for validation. My impression is that if you want to use these tests, I think they have important value, but it has to be, the key issue is the interpretation and relevance to the overall clinical picture. I cannot say, honestly, and my feeling is that I cannot say that if I want to use 2 tests, I cannot give an immunity passport. I cannot say that in those situations where we have all the background data that has not been negated in terms of neutralization and in terms of the detectability, although we have shortage in terms of doing cell culture and trying to prove all of these, I still believe that there is a major role, and antigen detection will also play a major role to minimize the cost and have more flexibility if we have reliable tests available in the market and approved. There are 4, as I mentioned, there are 4, some from from the East and some from Belgium, one from Belgium and the other from the East. But here, I think we have to be very careful to say that definitely we have antibodies. How long these antibodies persist, I don't know. In terms of what we have tested in our lab, in many cases, we have patients that go for a long period of time after PCR was positive, and we detected antibodies. We detected IgM, we detected IgG. Definitely, if you're talking about convalescent serum, many people are geared up for it, and there are protocols globally to utilize that. But does that depend on the level of the antibody? Does that depend on the titer of the antibody? Does that depend on what they try to quantitate in terms of the antibody? This is something. Are these neutralizing antibody? There are evidence that are showing neutralizing antibody. And what else do you say? And we can have a better play with this, because even I tried to test antigen detection, and I found antigen detection. I found them to be, I captured antigen from the specimen that are used directly for PCR. I took sample and used it with antigen detection kits. It is positive. And even with heat inactivation, they still are positive. Similarly, the antibodies, they are still positive if you heat inactivate or don't heat inactivate. The other part I would like to allude to, sampling in terms of the PCR and what you miss and what you don't miss. I think it would be much better reliability if you sample different sites, not only rely on one site or specimen site, not nasal only, You can go nasal, you can go buccal, you can go throat, and put them in the same type of transport medium or container and do the PCR. There would you minimize the false negative in terms of these kind of situation. So I believe that we still have to have some sort of standardized testing to settle many of the questions that are raised. Standardized testing, take into consideration the clinical, overall clinical picture, the timing where you test, and follow up in terms of those, and try to identify relevant antigens that can be implemented in the test. This is my thinking about it.
Thank you very much, Dr. George. Zia, do you want to add anything at this point?
I'll just comment on briefly on the question about phenotypes.
Okay.
There was some data published in the European Respiratory Journal in April this year, looking at the variability in the clinical presentation of patients with COVID. We see some patients who have mild disease and some patients who have severe disease. And they found that there is correlation between the phenotype of the virus and the severity of the disease. So there are 6 phenotypes. The first 2 would give mild disease. The third and fourth will give moderate disease, and 5 and 6 will tend to cause severe disease with ICU requirement. So I think
are the antigenicity of these 6 the same, or they differ? Do we have a mutation where we miss the antibodies? Have anybody done any study from one patient and tested the 6 or antigen from different 6 phenotypes that we are talking about? Is there any study like that? Now, this is another question. What we are talking about, Italy, they say they have a mutated virus, they raised it, but proved then in gene sequencing that was not different than the one from China or than the one from the United States. So are we talking about highly mutable type of virus? Or if you have this phenotype, but you should have a common denominator in terms of antibody. Now, in terms of their antigenicity. And I come to the denominators and numerators. Yes.
George, let Ziad finish his statement.
No, but he said 6 and finished, I think.
No, he didn't finish. He has something to say.
Okay, go ahead.
Ziad.
I think there has been some work done even in KSA by the Saudi CDC, where they've collected at least 400 samples at different intervals in KSA. And the majority of the early cases that were actually diagnosed in KSA were actually from phenotype 1 and 2. And that might explain the lower mortality that we're having in Saudi compared to other countries in the globe. Our mortality is 0.6% compared to the mortality of 1 or 2% or 3% in other countries. So I think this needs to be looked at in more depth by other investigators in different countries of the globe. I think we can open the floor for more questions so that we can
yeah. Thank you. Thanks to all 4 of you for some really important interventions.
Can I have one point here?
Yes, please.
Yes, I want to talk about the disease and the mask that you raised in relation to the question in the mask. You know, this formula that we have, disease is a combination of number of viruses times their virulence, or number of pathogens times virulence over the denominator of immunity. Definitely here, nobody knows what is the viral load, what's the viral load that can cause infection. Is it 100 copies? Is it 1,000 copies? Nobody has determined what is the infectious dose so far. What we are trying to do here in terms of social distance and terms of mask wearing is to minimize the infectious dose in order for our immunity to kind of encounter this kind of virus. Definitely this virus is highly spreadable and highly infectious in terms of this. But immunity, in case of minimizing the infectious dose to the human, this can be helpful in the social distance and wearing the mask. And probably when you have a symptomatic infection, by your antibodies, your immune system taking over and controlling the infection, not to go to disease stage, remaining asymptomatic or milder disease, This is probably where you are trying to build also herd immunity. And I agree with you about the mask.
Okay, wonderful, good. Well, let's go back to some more questions on diagnostic testing. Debbie, can you give us 3 more questions from the group?
Sure, Dr. Heyman. I'd actually, I know we're running short on time, so maybe I'll just I'll throw a few
We'll
out
try to,
there.
yeah, we'll try to keep going until half past.
No
So
problem.
give as many questions as you can, try to group them.
Okay, yeah, let me go ahead and do that. So
Yeah.
the questions have been around, so I'm just going to give 5 quick topics.
Okay.
When to discharge a hospitalized patient? Does serology testing have a role for people traveling? The role of antibody testing in low prevalence countries? The availability and role of both antigen and antibody tests? And then the last one is, are there special categories for labs to perform molecular and serology testing?
What was the last one again?
Are there special categories for the labs to do
Mhm.
molecular and serology testing?
Okay, fine.
And this one came
Okay, well,
from
thanks, Debbie. Dr. Ali, let's start with you on any of those questions. You're muted. You're muted, Dr. Ali.
I'm sorry. These are very sort of wide range of questions, really. I will start very quickly about the antibody testing and traveling. I believe no guidelines so far in any country about antibody testing and allowing people to travel or board an airplane. For simple reason that people still find patients with positive PCR and antibody positivity. Whether they are infectious, not infectious, I think there's a question mark. So I believe antibody test will not or may not be the best test for travel. For category, for serology, I don't think that you need special category for a lab, whether BSL 1, 2, or 3. For molecular, I think Dr. SAMEERA is an expert in this, and she might give us more on this front. SAMEERA,
Okay,
if you can.
thank you. Thanks, Dr. Ali. Dr. SAMEERA.
Yeah, thank you. Yes, for molecular assays, it's a standard molecular testing where you need a good setting. You have to have a clear area for extraction, separate, totally separate from the detection room. You have to have a negative pressure room. You have to have a certified biological safety cabinet. So you are talking about the biological safety containment level 2 or higher. It's very important that the staff performing the test, they know exactly their safety standards, because you have to make sure that your staff are safe before putting them in testing for patients. It's a highly infectious area, so, and it's a live virus when we process the sample. So it's very important to follow whatever standard viral detection procedure here.
Thank you, Dr. SAMEERA. And Dr. ZIAD, do you want to talk about discharging the patient, or I know you've had some discussions on that recently.
That's a very good question, and we get these questions almost on a daily basis from staff in the healthcare facilities. I think early on, we used to keep people isolated for 14 days, and we won't release them until they had 2 negative PCRs 24 hours apart. But as was mentioned by my colleagues over the last hour, data have shown that actually you get fragments of the virus after day 7 or 8, but you don't actually you don't capture the virus after day 10. So I think we have started to give people time until they're free of symptoms for 2 days, or at least 7 days since the beginning of their illness. And as far as the questions about availability of antibodies and antigen tests, I think they're available, but I think there's concerns about their validity and sensitivity and specificity. So we're waiting for standardization of these tests before they can actually be purchased and used.
Thank you, ZIAD. Dr. George, do you want to add anything to this discussion?
Well, I agree. This is very important in relation to the PCR. After 2 negatives, but also I would feel much better to have the serology with it simultaneously.
Okay.
This will give you more comfort.
I think that's right, and I think that's what Rosanna has told us as well. So let me just try to bring this to a close. I'd like to give each of our panelists just to be thinking about one sentence that they'd like to leave everybody with, one thing that you think is very important. But before that, I just want to turn to Rosanna to ask if you want to add anything more, Rosanna, at this point. And thanks for organizing this.
Thank you. And I think it's really important for us during this time of the pandemic to be discussing these issues. One of the things that we haven't had and still don't have is a gold standard for measuring how good serology tests need to be. And so without that, we say we really need good sensitivity, especially we need good specificity. But because we don't have a gold standard, it's hard to know, especially for sensitivity, how good we are. I mean, we could only compare tests that we have at the moment and say how much concordance they have in terms of identifying positives and negatives. And for specificity, we could, use a test on all kinds of different types of viruses that have the potential to cross-react. But still, there isn't a really gold standard to say how good is good enough, right? And so right now, I'm on a WHO committee to decide on the target product profile for molecular tests, antigen tests, and antibody tests. And hopefully that would come out soon so that we could say, okay, how good is good enough, and what do we measure that good enough against as an interim gold standard, even if it's not the gold standard, right? Thank you.
Thanks very much, Rosanna. So now, I'd like each of the panelists to leave us with one message that they feel is most important as we move ahead with this. And I'll start with Dr. Ali again. Dr. Ali, one sentence.
Thank you. One sentence made of two ideas. Whenever you want to introduce antibody tests or serology tests in your lab, you must look at the literature and find out what is the sensitivity and specificity in larger studies, especially the commercial kits.
Yeah.
What antigen they are using, very important because that affects the sensitivity and specificity. And the last idea is that rapid test does not seem to perform as well as the standardized ELISA and automated ELISA test. Thank you.
Thanks, Dr. Ali. Dr. SAMEERA. Last words of wisdom for us.
Yeah, again, we need time to understand more about all of this. And I think nowadays with the number of cases increasing, people are going toward the antibody testing mainly to know if they have previously got infected and they are immune. But I guess with the time I see people getting it more relaxed a little bit, so the anxiety level, which I can tell by the number of samples I receive every day, is getting a little bit much better, mainly because we start to understand some scenario and the genotype of the virus that is circulating in our community. It starts to be more, there's more cases with no symptom at all. And I'm sure all of you did see people around you who's totally asymptomatic. So I think we need time for full understanding of what's going on. But I guess until now, it's the molecular assay is the mode of diagnosing cases, and we're beyond that. Thank you.
Thank you, Dr. SAMEERA. Dr. George, some parting words for us.
The literature has been influxed with good, bad, and ugly information. I would like to emphasize that there are tests available, there are limitations. However, the message should be you have to use these tests after appropriate validation within your lab and correlate with the clinical picture as a whole. You cannot take isolated situation. If you do this, I think we'll be on the safe track.
Thanks very much. And now to ZIAD, who opened this meeting. ZIAD, I would like you to say your final words of wisdom for us.
I guess my greatest thanks and gratitude to you, David, and Rosanna, and Debbie for hosting this event, and also to my dear colleagues who joined us as panelists from the region. I know how busy they are, and I'm really thankful for them to dedicate this time to the group. And also, I would like to thank all the people who listened to us and also asked all these wonderful questions. I can only close by saying that these 6 months have taught us how to collaborate and how to work together as one team. I don't think we have seen any time where each of us have worked so closely with each other over the last 6 months. And I think this is very fruitful, and I look forward for a future collaboration with all of you in the near future. Thank you.
Thank you very much, ZIAD. And Debbie, one last word from you before thanking you for having organized this for us.
Oh,
Debbie?
no problem. No problem at all. This has been great. And again, please, if you can just take a few minutes to complete our survey. It allows Rosanna and myself to continue to have these educational webinars, which is, you know, to echo all the panelists, I think are very useful and informative during this time to come together as one community. And thank you, Dr. David Heyman, for taking time out of your busy schedule to help moderate this.
Thank you. And we'll try to get all the questions that were not answered by the panel answered and sent off. Is that correct?
That is correct, yes. We'll be also pulling together questions from all the regional webinars we've had across Asia, Africa, Latin America, and putting them into FAQs to send out to everyone.
Wonderful. Thanks very much, Deb. So with that, thanks to all of you, the panelists, to Rosanna, to Debbie, and of course to you, the participants, for having tuned in and listened to us for this hour and a half. Good luck as you continue your work.
Thank you.
Thank you.
Thank
Bye-bye.
you, everyone.
Great
Thank you.
Thank you. All the best.
Bye-bye.
And Rosanna too.
Bye-bye.
I like your presentation. Bye.
Thank you. Thank you very much. Yeah.
All the best.
More work needs to be done, right?
Absolutely, definitely,
we'll
definitely.
continue.
And I concur with that. Ali.
Yeah. Okay. Bye-bye.
Yeah, all the best to you all.
Yeah.
SAMEERA تعرفنا عليها. Bye. Bueno.